My name is Claire Payne. I'm a psychiatrist. I work at Mount Sinai Hospital in the psychological trauma program. But I guess my deep excitement that Professor Patel is here is because I've known him for almost 15 years when we started our partnership between Addis Ababa University in Ethiopia and University of Toronto. We now have 24 programs and send about 80 to 90 volunteers out to Addis Ababa University to teach in a bunch of places. But we started with psychiatry. And Dr. Patel was there to encourage us and to guide us. And one of the spin-offs of helping start the first psychiatry residency program in Ethiopia was we got a Grand Challenges Canada grant to integrate mental health services into primary health care by training non-physicians, but general nurses who hadn't had any previous psychiatric training. And we taught them we trained 500 people who taught them to screen and treat with IPT. And it was a very exciting learning experience for all of us. But I remember rushing off to ask Vikram, how do we do this? I wanted to, Daisy did a lovely introduction. I just wanted to add a couple of things. And just to emphasize a bit more about the Gardner Awards, the Canada Gardner Awards, that was only announced 3 days ago. And this award, there's a number of categories, but this award recognizes the world's most creative and accomplished biomedical scientists and global health researchers who are advancing humanity and the world. The particular Global Health Award has grown significantly to become one of the world's most prestigious awards, recognizing excellence in global health research. In fact, 380 awards have been bestowed on laureates from 35 countries, and of those awardees, 89 have gone on to receive Nobel Prizes. We got them first. So there are a couple of other things I wanted to say. Vikram, some years ago, in the 90s, wrote a book called Where There Is No Psychiatrist, which is one of the most, it was very helpful when we started the residency program in Addis, but many of the people who were teaching into that program who are here today, and many more who I want to recruit, they loved that book, not only because of where they were working, but how useful they thought it was for University of Toronto residents as well. Vikram really spearheaded the movement of global mental health in the Lancet series in 2007, 2011, and pushed global mental health into center stage with the tagline, "There is no health without mental health." And perhaps today we're going to hear more of, I think, probably the most exciting aspect of his enormously broad work, which is kind of reverse innovation or trickle-up innovation. And there's a great talk, he's done many great talks, but if you go to YouTube, you can see what the rich can learn from the poor. So thank you, Dr. Patel, for coming.
Thank you, Claire. Thank you, Claire. And I want to first of all just start by, a word of appreciation for the organizers of this event for inviting me. I'm not really someone, as you'll see historically, someone who's invested a lifetime work as David has, for example, in psychotherapy research. I'm a relatively new convert. But you'll see, like all new converts, has now become a passionate believer. I also wanted to say something about the Canada Gairdner Award. I must say it is a huge honor for me. The previous winners are people I have considered iconic figures in the field of global health, including my the director of the institution I worked for in London before I joined Harvard Medical School, Peter Peart. But my love affair for Canada, which began when I first tasted poutine, will continue now. Will continue thanks to this wonderful award. I'm going to really be focusing a lot on the work that's been happening in the low and middle income world, but I did want to say that I thought David's presentation was a remarkable example of how science can actually lead to really large-scale changes in practice. I'm afraid we don't have any such examples as yet in the developing world, and maybe in our discussion, we might see how perhaps the experiences of IAPT can build on the science that I will be really focusing on, because that's all we have from the developing world to a large extent, can see transformation at a global level. So let me start first of all by giving you a bit of a reality check on how many people actually receive what we already all accept are amongst the most effective and evidence-based of all, not just mental health care interventions, but healthcare interventions in the world. I would say in India, for example, the population that I have spent most of my life working in, it's about 0%. Almost nobody receives an evidence-based psychological treatment for any mental health condition, whether it's autism in childhood or depression in adulthood or drinking problems. It's quite incredible when you think about this. I don't know of any other health condition in human history which has been denied access to something that we know can transform lives, and we've known this for at least 40 years, if not longer. Historians of psychotherapy will probably say it's even longer than that, but at least contemporary forms of psychotherapy, it's at least 40 years. It's astonishing. And there are many reasons for that, and I want to touch on 2 reasons and then several more that I think are structural in the next slide. The one reason that we've often thought is, people like us would often argue, is there's not enough of us. There are not enough mental health professionals who have been trained to deliver these therapies. And by training, we typically assume that means a psychiatric qualification, or some kind of master's or PhD qualification in, for example, clinical psychology or clinical social work. So the usual prescription to address the supply side barrier is invest more in us, in our kind of services. What we have less often acknowledged is that there's also a demand side barrier. Let's be absolutely honest. If it was just a case of supply, then rich countries in the world should not witness the enormous, enormous lack of access, the barriers to access that David spoke to in his lecture. Clearly, there are also issues to do with how people understand their illness experiences. And this is even more true when you cross cultural boundaries. I have rarely, in my work in India, and I also have worked extensively in sub-Saharan Africa, ever met anyone who meets a PHQ-9 criteria of depression as actually thinking that they have a mental health problem. Leave aside even mental health problem, they may not even think that they have a health problem. What they will really conceive of is their suffering is an extension to the difficulties in their daily lives. And I'll circle back to this issue of how we biomedicalize our target conditions and how, in many ways, that often alienates ordinary people with those conditions from actually seeking care. Demand-side barriers are fundamentally important. But there is a larger structural barrier, a set of different barriers, and we spoke to that a little bit in the panel earlier today that I also want to mention because I think they are very important when we think about the future of psychotherapy. The first barrier is my profession. I am by training a psychiatrist, and I will be quite blunt with you. When I said earlier that I actually am a much later convert to psychotherapy than many of you here in this room, I was trained in a field that believed wholeheartedly that the biological explanation for mental health problems would mean that the solutions would always be pharmacological. And it would be fair to say that this also represents the worldview of most of my colleagues in most parts of the world. The idea, for example, a couple of weeks ago, there was this trial that has developed a new medication for postnatal depression. I don't know how many of you saw it. It's got enormous amounts of press. It is the most intensive treatment you could possibly imagine. It involves bringing women into hospital and giving them intravenous infusions of drugs for a minute effect on a depression score. But the world of psychiatry is celebrating this as one of the most radical new discoveries in our field. I do believe when I look back on my training as a psychiatrist, the devaluing of psychological treatments that was underwritten by the fact that we had such little exposure in our training continues actually to be one of the great barriers. Why? Because in most parts of the world, psychiatrists are in the most powerful positions of making decisions on how resources are allocated for mental health care. And that is one reason why I myself, for the first part of my career, largely saw psychological treatments as a distraction with a very heavy emphasis on, for example, the use of antidepressant medication. It was only when I discovered that very few people wanted those medicines, and that actually even when they got those medicines, very few people ever completed a course of those medicines. And by that I mean in primary care, which is really where most people with depression will present themselves. I had to actually start changing the way I thought. The next important barrier is that part of this idea that medicines work in all human beings, because there's a biological basis to mental illness, also meant that psychological treatments did not travel across cultures because they were based on worldviews and illness narratives and beliefs that had only ever been studied in weird populations. That is to say, the kinds of European populations, middle-class populations attending specialist facilities. So there was a very strong belief that these theories that underpinned the main psychological therapies did not travel across cultures. So as a global health practitioner, that was another reason to dismiss it as being a valid form of intervention. I've already spoken to the area of commercial, but I do want to emphasize this. The fact that the moment a pill is approved by a drug regulatory authority means a whole juggernaut of pharmaceutical interests will start promoting that medicine, and promoting it, for example, through active collusion of frontline providers who are prescribers is not something that we can ignore when we think about scaling up psychotherapy. Then there is another kind of barrier which is also important, which is the territoriality of people who develop treatment packages. The fact that many of the psychological therapy packages are not open access. The fact that they're impossible for people in developing countries to actually get to. To either train in them, you have to go to very expensive universities. To actually access them, you have to pay proprietary fees. In a way, you could argue that's what you do for medicines anyway, so why not psychological therapies? Nevertheless, the fact that there's been a mushrooming of psychological therapy packages, many of which are associated with enormous proprietary costs, has been another important barrier. People are not interested even in many of these academic communities for the dissemination of their own treatments. And I've already spoken about guilds. And so I won't say much more, except to say that I was very fortunate, having started my career after training in Britain as a psychiatrist in the same place as David, at the Maudsley Hospital. I found myself in Zimbabwe. And one of the most important things I discovered when I started working there was I was one of 9 psychiatrists in the country, in a country of 10 million people. But more importantly, of those 9 psychiatrists, 8 lived and worked in the city of Harare. So these averages don't actually capture the true distribution of mental health professionals. So about 8 or 9 million Zimbabweans had access to one psychiatrist. And for those of you wondering how many psychologists, there were about 6 psychologists in the country. So it was very clear that in that kind of context, there were real challenges, but there was one enormous opportunity. There was no guild. And so therefore, you could actually begin to think out of the box and learn from other areas of global health. I was myself first interested in psychological treatments when I saw 2 trials that really changed the way I thought about these treatments in the global context. Remember, cultural relativism was also a very important obstacle in my mind. The first was this trial that was published by Paul Bolton and his colleagues, which showed that lay people in villages in southern Uganda, an area that was being ravaged by HIV, could be trained to deliver interpersonal psychotherapy in a group format. IPT, I'm sure all of you are familiar, has historically been an individual treatment, typically delivered to people with severe depression and largely delivered in specialized settings until this kind of work transformed our understanding of how you could disseminate this treatment in this sort of context. Very large effects in favor of IPT as compared to the control villages. And the next trial that heavily influenced me was this one, which was led by my colleague and friend Atif Rahman, where he demonstrated the use of lady health workers who were community health workers in rural Pakistan to deliver a cognitive behavioral inspired intervention, which was called the Thinking Healthy program for mothers who are depressed. Both of these trials published in leading medical journals, which I think also marked a growing interest in the general medical press for these sorts of innovative ways to improve access to quality mental health care. I studied these two. I collaborated a lot with the authors of both of these two groups and thought what we really needed was to assemble the different lessons on how these groups had innovated the design, delivery, and evaluation of psychological treatments in these extremely resource-poor contexts to, as it were, define a pipeline, a kind of a methodology through which you could fast-track the development of behavioral interventions in low-resource contexts that addressed these kinds of barriers that I spoke to earlier. It's with that in mind that the Wellcome Trust, which I have to also acknowledge has been the single biggest foundation support for me and my work, going back from 1995 actually, all the way through till today. The Wellcome Trust, one of the sequence of fellowship grants that I have received from them, about 8 years ago, I received this particular grant to launch this program, which really sought to, as it were, codify a design methodology for brief psychological treatments. Actually, I should say it should be scalable psychological treatments. I'll come to the word brief a little later, because of course that is an intrinsic requirement for acceptability of interventions. So to develop scalable psychological treatments which address both demand and supply side barriers. Now, some of you may wonder, why is the word scalable highlighted? It's for this reason. My understanding of the history of psychological treatment development was that historically it began with a fundamental theoretical understanding of human behavior, which was often actually informed furthermore by animal behavior experiments. Over a very systematic process, there was a translation of this theory into techniques that were then tested in highly specialized settings by highly trained professionals in highly controlled settings, but also with people who were clearly not representative of the real world because they were in those settings to begin with. And once those treatments had been developed and shown to work, then we began to figure out the challenges to dissemination into the real world. That's my simple way of thinking about where we are today with many of the psychological treatments. We know they work, but the problem is that they can sometimes be very difficult to scale up in the real world for all the historic reasons I mentioned. So here we were positioning scalability as an equally important property of the treatment as effectiveness. We weren't only saying it has to be effective, because if it's effective but not scalable, well, that's not such an exciting result for us from a global health perspective, given the unmet need. Well, we say it has to be scalable as well as it has to be effective. And to be scalable, it has to address both demand as well as supply side barriers. And then what we wanted to do was, having assembled the lessons from experiments like Paul Bolton's and Atif Rahman's, and developed a kind of design methodology to test that methodology for the design of novel psychological treatments. And we focused on two that the World Health Organization's MHGAP program had identified as being ones where psychological treatments were first-line therapies: severe depression and harmful drinking. Why severe depression? Because we do know that mild depression and moderate depression often does not need a very active clinical intervention, but also because depression is a very common condition, we wanted to focus our resources on those with the greatest level of need. And why harmful drinking? Because we know that quite opposite to depression, people with severe drinking problems, dependence, actually do often need a more clinical biomedical approach, mainly to manage their withdrawal. So actually, paradoxically, for drinking problems, it was at the less severe end that psychological treatments had been shown to be the first line. So we looked at the stories of Paul Bolton, Atif Rahman, and a couple of other important trials by then, and really identified two key research questions that any design methodology should address. The first was, what is the architecture of the treatment? I can use a metaphor of a house. You know, what are the different rooms that we need in the house? How do these rooms connect with each other? Which room should come first, the sequencing of the rooms, and so on. You can begin to see, of course, how that metaphor would work for psychological treatments. And the second is, once you've got a design of that house that is very importantly grounded in theory, how do you actually build that house? How do you actually deliver that treatment? And we then further elaborated guiding principles for each of these two questions. The first was to recognize the international evidence. So we did not believe entirely that treatments had to be completely grounded in the local culture. We did have an assumption that there are elements of human psychological experience that are human. That is to say, they belong to every human being everywhere in the world, and so we could and should learn from experiences in the global north. But equally, we also had to recognize that people in the world, most of the world, hadn't been waiting around for people like us to appear with our treatments to help themselves to deal with human health conditions that are as old as humanity. In other words, that there were, in fact, many other homegrown techniques and strategies that people had been using since millennia to help themselves when they had depression or symptoms of depression or drinking problems or other addictive problems. And we needed to actually find a way to merge the contextual help-seeking strategies with those that emerged from the global evidence. And then how the treatment should be delivered was really about essentially dealing with both the lack of mental health professionals. In other words, the treatment had to be deliverable not by a fantasy mental health professional that one day we would want to recruit, but actually by a health provider who already existed on the ground. We had to ensure that the treatment was feasible for delivery by existing providers, and secondly, that it also had to be acceptable to the target population. And so, for example, if the target population did not consider their experience of distress as a health condition or a mental health condition, we needed to find a different way of engaging them in the treatment. Now, this slide simply shows a schematic of the kind of steps that we undertook in order to actually develop the design, as it were, called a design pipeline. So this was the first part of the design pipeline, which was essentially to identify the components or the active ingredients of the treatment. And I'm not going to go through that in any detail, but I will refer to some publications that you can look at in more detail. So the end result of this particular step was the identification of a set of clinical strategies that were both feasible and acceptable, but which also had been demonstrated to work in diverse contexts, as well as being built on a strong evidence base. The next important step was to develop a theoretical framework for the treatment, and this typically involved experts in psychological treatment science, particularly focused on one or the other condition. Remember, we were working with two separate conditions in concurrence. And then you had a set of clinical case series and pilot trials that really tested various iterations of the treatment being delivered in the real world by providers who represented the frontline workforce which already existed in the healthcare system. We spent 3 years, which I think is actually not a long time to develop a treatment, because we were really on fast-track mode. We don't have the luxury of a lot of time in global health. We really do need to move swiftly to develop the one treatment for depression, which is called the Healthy Activity Program. What's really interesting as you see this slide is perhaps no surprise to most of you in this room, because all of you already know behavioral activation as one of the most well-established evidence-based approaches for depression in the global north. So what's new? Well, actually nothing is new. And this is one of the most important discoveries for our field. And I will turn back to this because for so long, we have worked on the premise that treatments developed in one cultural context don't travel in others. But we had to go through this design process to arrive at where we might have been 3 years before, but we went through this by going through this incredibly grounded process of actually studying how people help themselves and discovering that activation, behavioral activation, is in fact something that people historically have been doing in order to alleviate their own experiences of depression. A very important part of the process was acceptability, and a key element that's emerging from the literature, and I'll talk about that in a moment, is the need for very brief treatments, because people's lives are difficult. People's lives are those where they cannot engage for very long scales of time for the delivery of the treatment. So few sessions in a relatively short period of time, front-loading as much of the treatment's active effects as early as possible to get the earliest response in order to engage people was a very key lesson. We also thought it's extremely important for us to have a theory of change of the treatment. Right at the outset, we believe very strongly it isn't just good enough to look at effectiveness, but also the mechanism through the treatment's effects. And so, for example, this is a kind of a theory of change of the treatment. And as you can see, there are the components of the treatment on the left-hand side, which all of you will immediately recognize looks extremely similar to any BA manual. The ways that we hypothesized the treatment could work that we could then measure as just to ensure that mechanistically the treatment was working through the theory that we had set out, and then the sorts of improvements we wanted to see, which include not just improving mood, but also improving social functioning. Concurrently, we were also developing a treatment for drinking problems, which I will not speak about more, simply to say that we were actually testing this design pipeline with two completely mental health conditions at the same time. And again, you can see great similarities with any other kind of brief intervention that you might see for harmful drinking that you might be practicing here, and also similarly a very brief treatment. We then carried out trials. Now on this slide, I'm showing you a summary of the main trial design. Importantly, as David also described earlier, it's not just good enough for us to demonstrate remission in the short term, but we also want to look at remission in the longer term, and especially recovery. That is to say, when you achieve remission at both of these different time points. We were not only interested in clinical outcomes, but social and also, very importantly, economic outcomes, because this is an extremely important case to make should the results be promising. But perhaps the most risky decision that we ever made was this one. For those of you who are trialists, you will know that in order to ensure that the treatment is delivered in the way that it was designed to be delivered, you tend to control every possible aspect of the provider. Typically by, for example, having very well-trained, highly skilled providers, minimizing the variability between providers. Here we were already working with lay people to deliver these treatments who had received 1 week's treatment in behavioral activation. And now, my trial steering committee, comprising some of the most respected global health mentors in my career, insisted that actually I should have the same providers delivering both treatments. Not two sets of providers, but the same provider. As you can imagine, as a principal investigator of a grant, recognizing the threat that would mean to the positive results that I was hoping we would find, and then the difficulty of interpreting those null results, I was pushing back. But they made a very strong argument. They said, well, if you really believe in scalability, is there any prospect that any country that you know of will have an alcohol counselor and a depression counselor when they have none so far? And, well, you know, there was a rhetorical question because there was only one answer to that. So they said, well, Vikram, in that case, if that is your belief, well, then have the same person deliver both treatments. And so I argued on, but they're different treatments, they're different theories, they're different populations. One is almost entirely men, the other one is mostly women. I mean, everything is different. And are you asking me that lay people are going to switch between these two different theories according to whoever the next patient is in routine primary care? Well, that's what the real world is, that's what you should test. So I took that risk. Our primary outcome results were published in The Lancet in 2017, and our sustained results, which also included a mediation analysis, were published in PLOS Medicine about a year later. And what I'm going to just very briefly present to you is just the depression results, and then move on to thinking about the larger global implications of this work. So the first thing I want to talk about is acceptability of behavioral activation. Now, when I started work in this field, I was often told by my colleagues, our patients have no time for talking treatments. That's the first thing. I was also told that actually they prefer pills. How often have some of you heard that actually patients like medicines? This is, I'm talking in the global context. And it's interesting to hear David's remarks about the global north. But the global south, that's usually the idea. People like pills. They don't want to have talking treatments. Well, you can see here that that's not true. Yeah, it's not true. 70% of our trial participants, mind you, these are not even routine care. These are people who are first having to take part in a trial and have all the assessments that go with a trial, which is no fun for any of you who've taken part in a trial. 70% of them completed the treatment. To me, this is a very important indicator of acceptability of psychological treatments, and actually one that I myself, at the time, was very surprised by. Here's remission rates, and I won't again speak too much about these results, but at 3 months, as you can see, a 60% increase odds of remission. This is for moderately severe to severe depression, by the way. So we're talking about people with a PHQ-9 score of 15 and above, not 10 and above. So these are really at the extreme end of the continuum, and remission was defined by a score of less than 10, so they had to move quite a lot into the low symptom, free symptom zone. And as you can see, a sustained enduring effect 12 months later. You do see similar, a much larger difference, of course, at 3 months, but not surprisingly, that gap closes a bit, but doesn't completely close at 12 months because of natural remission. If I had to present these differences in a slightly different way, we're looking at the clinical trajectory for these two groups. About 490 individuals took part in these trials for depression. And if you look just simply at the red bars, which showed no response at all over the entire 12-month period, as you can see, 80% of people showed some response in the behavioral activation arm as opposed to 50% in the control arm, which by any account is a very impressive result when you consider this is 6 to 8 sessions delivered by a layperson in routine primary care settings for people who have never received any psychological treatment before in their lives. Now, I'm just going to show you a brief 2 or 3 minute video, if it works, which just illustrates some of the key players and some of the key experiences that happen in these trials. Now, let's see if that works. How it does.
म्हाका खूब टेंशन जाता तकलेन आनी हांव बरें नासता. म्हाका जेवपाची बी याद उरना आनी कितें खावचें कितें काम करचें अशें म्हाका दिसत ना आनी भुरग्यांकूय हांव केन्नाच सारकें वाडिनाशिल्लें. टायमूच म्हाका असो बसोनूच हांवें काडप. म्हाका खूब टेंशन जाता.
With depression, we've developed a very specific treatment called the Healthy Activity Program. This is a treatment that's based on the concept that when people become depressed, they stop doing activities that they typically do.
Actually, पहले हांव सोरो पियेतालो आनी सोरो पियेता हितून अशें जातालें की थोड्या क्वॉन्टिटीन पियेतालो मागीर क्वॉन्टिटी वाडली. तेज्या उपरांत मागीर हांव लग्न जालो. लगीन जावन थोडे दीस कमी केले. पूण परत फ्रेंड सर्कला भितर रावन म्हाका सोऱ्या कडेच वयचें अशें दिसलें आनी सोरो पियेतालो. लोक सुद्दां म्हाका जेन्ना पळयताले तेन्ना बेवडो कसो अशें.
Alcohol use disorders are a collection of a range of alcohol problems which are of increasing severity and can be called as hazardous drinking, harmful drinking, and dependent drinking. Counseling for alcohol problems, or CAP, is an intervention that's been developed for harmful drinkers. So we have a range of patients who come to primary care. Our treatment is designed to cater to all of these different types of patients.
तिणें स्वता आपणे प्रयत्न केलो की हितूंतल्यान भायर सरपा खातीर. जे आमी सेशनान उलयतालीं, जे आमी 30 ते 40 मिनटां बसून उलयताले तेन्ना तिणें खूब बऱ्या तरेन ते करपाक लागलेली. तिका अशें कुळाघरांतलें काम आसा जें रोंपे लावपाचें, नडणी काडपाचें किंवा कुळाघरान जें कितें कितें ती लायता तें तिका खुबशें आवडटालें आनी स्वता ती तितूनूच बिजी उरताली पयलीं. सो ती कशा तरेन सुरवात करूं शकता हेजेर आमी काम केलें.
तेणी म्हाका 10 मिनटां दिलीं, मागीर 15 मिनटां दिलीं. मागीर म्हाका तें काम बरें जाता अशें दिसलें. हांवें 5 मिनटां 2 मिनटां वाडोवन करप आनी म्हाका आतां वखद सुद्दां नाका. बरी जाली तितूंतल्यान आनी बरी आसा सामकी.
बरे भशेन ते समजोवन सांगपाची पद्दत आहा तेंचे कडेन. अशें जर प्रत्येक म्हाजें तरी बरें जालें पण आनी कोण सोरो पिनारो आसा बरो खूब सोरो पिता तसल्यांक जर असले कावन्सिलर जर मेळ्ळात तर तेंचो बी सोरो सुटोवंक शकता.
So that was just to give you a little snapshot of the kind, we have actually quite a large video library, and one of the things I will say in global health which is really important is actually having video documentation of people who have experienced these interventions, because they are such a far more powerful way of conveying these results than statistics might be, particularly for certain audiences. So our key conclusions from these two trials were that this particular design methodology had led to brief treatments that were feasible for delivery by non-specialist providers, that were acceptable to populations that were completely treatment naive, that had never ever received a diagnosis of a mental health problem or been offered talking treatments in their whole lives, or in a community which had never been offered these treatments. And these were delivered in routine healthcare settings, and these were also great value for money. To give you a sense of how much it costs, when you count all the costs, including the salaries of the frontline workers, it costs about $2 per person who was treated. Now, many of you will know that this is actually there's always an allegiance bias in psychotherapy. This is a very important, one of the very important biases that one has to be wary about. Luckily, of course, the treatment that we were using are pretty standard. There's nothing original about it. We call them the Healthy Activity Program. It's a branding issue. But actually, it's essentially BA, but a very brief form of BA. It's nothing more or less than that. Nevertheless, it was a very locally developed treatment with a locally developed sensibility, and we wanted to see how well it would work in other contexts. So I was very fortunate when a separate team from Nepal wanted to actually adopt these treatments in a large scale-up program of the World Health Organization's MHGAP guidelines. The MHGAP is a training program for primary care practitioners where they learn about the diagnosis and treatment of a range of common mental health problems. And what this program wanted to do was to ask the question whether the addition of this behavioral activation treatment delivered by community counselors enhanced the outcomes of people with depression as compared to what was quite an active comparator arm. This was a 7-day training program for primary care practitioners, which had already been approved by the World Health Organization. And so here you can see the results that were published only last month, which showed, for example, in the case of a change in symptom severity, the red line is the one that the individuals who received the behavioral activation treatment, but also in social functioning, very important differences, statistically significant differences, both in symptom severity as well as change in functioning, a small sample, but sufficiently large effects to be detected in spite of the sample size. Now, I want to turn to the larger evidence, and here I want to just remind us all that these are only a few trials that are presented. But in fact, the body of evidence on the delivery of psychological treatments from the Global South is enormous. Enormous enough that there are now at least a dozen different kinds of systematic reviews that have started examining the evidence base on these interventions from low and middle income countries. Here are two that I want to highlight because I've been involved with them. One of them is led by Daisy Singler, which examined these treatments, but also broke down the treatment characteristics. For example, the type of provider, where the provider delivered the interventions, the content of the interventions, and so on. But before I actually turn to some of the key lessons from this really tremendous body of evidence, that in my mind is probably the most incredibly generalizable body of evidence of any mental health care intervention globally, I want to turn to the kind of bias that I had in the mid-90s when I first moved to Zimbabwe. And that bias, remember, I was also trained in medical anthropology, and that bias was really that people were very, very different everywhere. And they were so different everywhere that I could not take anything from my training in the Maudsley Hospital to Zimbabwe other than the fact that at least human biology was the same, and therefore I could take the pills with me. And I can tell you, having looked at this large body of evidence, it is so clear that the theoretical frameworks for psychosocial interventions are the same across cultures. And this, mind you, this large body of evidence is not the classic old world imperial kind of research agenda where people parachute in and do research and then parachute out. At least half of these trials were conducted by people who actually live, work, and have trained in a university or in an academic setting in their own country. Many of these have actually started with a very strong grounding in cultural context and realities. And so for me, this is a really important lesson, which is that psychological pain and suffering are indeed just as universal as physical pain and suffering. And secondly, when I look at the innovations that I'll briefly summarize on the next slide, what really struck us as we synthesize this evidence is that the innovations that we see to improve access are not so much about cultural differences, but about social class. And so when I looked, for example, at the work of Jeannie Miranda with African Americans in the US, what struck me is the stuff she was doing looked exactly like the stuff that I was doing in sub-Saharan Africa or in the slums of India. And that instead, when I looked at rich people in New Delhi or Bombay, they were acquiring the same kinds of ideas that people who were relatively wealthy in the West did. So it seemed to me that one of the challenges for the access of accessing evidence-based psychological therapies was actually social class barriers, and that we had to think about how we could get these therapies out to a much broader swathe of the population. I was very interested, again, in the equity analysis that we saw from IAP, because I think that's exactly the kind of evidence we should be looking for. So what does this evidence help us do? It helps us redefine many aspects of psychological treatments. First of all, where we deliver the treatment. Of course, why is very obvious. It's because this is a preferred form of treatment for most people when given a choice. But also, we now know that many of these treatments also produce enduring effects, and because they are lessons on how to manage your own emotional states, they also have very great value in dealing with a variety of stresses and threats that might occur in the future. Where is very interesting, a lot of these treatments are being delivered at home. Now, some of you may be amazed by that idea, but actually we already do that with TB. And, you know, somebody was remarking, why do we question when we have to deliver, you know, we talk about cost when it comes to mental health care, but we don't talk about cost when it comes to physical health care. But actually for TB treatment, we think of what's the single biggest innovation in TB treatment. It isn't a new medicine. It's a guy on a bike who comes to your house and watches you take a pill every day. That's what direct observation TB tuberculosis therapy is. And that is exactly what we're doing also with many psychological therapies, is delivering it in the homes of people. And it's important to recognize a lot of people have enormous social problems in their lives when they have mental health problems. And the idea that we're sitting in our office waiting for someone to turn up and they don't come up, and then, you know, let's be honest, many of us get pissed off. Many of us think, you know, what a bad patient, you know. This person really doesn't deserve our attention. I think sometimes we fail to recognize, you know, the way people are entrapped in very difficult lives that makes them coming at 11 o'clock in the morning at a time that suits us, to an office that suits us, really, really very, very hard to do. So a lot of global health innovation has really been about making healthcare convenient, not for the provider, but for the person who's receiving healthcare. The what is also important, and I think it's, I was interested in, IAPT is very clinical, and a lot of my work has been very clinical, but most of the work of global mental health innovators is actually psychosocial. I think the word social is really important. And this is because for most people with mental health problems, social problems are actually bedfellows of their emotional and psychological suffering. But whereas perhaps in rich countries you could say, oh, by the way, your husband is violent, so we'll deal with your clinical symptoms, but you should go see that person for domestic violence. But that person does not exist in most other parts of the world. And therefore, our frontline provider has to do a double job, not only deliver a psychological treatment, but also be able to be a navigator to help the person manage some of their social problems. So the clinical and the social need to be often addressed together. And we've already heard a lot about training and supervision. So the how is extremely important. The devil lies in the detail of how you create this workforce and support them in order to deliver these interventions. So I want to now turn to some of the key design principles that I would like to suggest are the ones that you could consider as being essential for the design of psychological treatments or behavioral interventions in these sorts of contexts. The first is we must learn from both kinds of evidence. It's neither either or. It's not just the case that we look at systematic reviews of the psychological treatment literature, which will always be biased to certain populations, or it's also not the case that it can only be about context. There will always be lessons that we can draw from both. I'm increasingly impressed by how parsimonious these treatments are. Very, very few of these global health psychological treatments are a whole package of anything. They tend to be really stripped down treatments. So for example, behavioral activation is not a whole package of CBT, it's an element of CBT. And I'm seeing a lot more of that emerge in the literature, much less with anxiety disorders, but certainly with the mood disorders and PTSD, I'm seeing a lot more of the efforts at stripping down complex treatment packages into more specific elements. Why? Because of course they're easier to learn, they're easier to supervise, and then for the person who's receiving the treatment, they're also easier to master. And so the idea is, if that can work, maybe not as well as the full package, but it's easier to scale up, that is the kind of approach in terms of the active ingredient. Really focusing on front-loading with few sessions so you get maximum benefit as early as possible, because let's be honest, we really engage with treatments when we feel better quickly. Things that don't make us feel better quickly are the ones we're going to stop. And I think the same idea from somatic medicine applies just as much to psychological care. Competency-based training, so we don't need our frontline workers to understand the whole neurophysiology of depression and the history of behavioral interventions. No, we just have to figure out this is the theory by which people actually become depressed and how depression sustains itself. And so let's see how we break this vicious cycle, etc., and move very quickly onto the actual practice-based skills that they need. So a lot of the training actually is on the ground training rather than in the classroom training. And one of the other big bottlenecks is supervision. So we've been looking very much at moving away from expert-based supervision to peer-based supervision. Again, really learning from the larger body of pedagogical science, which is showing that when students actually supervise one another, they in fact arrive at an average assessment of quality that is not that far off that that might be achieved by an expert. We've now been applying this design pipeline to many other mental health conditions. We have a whole program of work in India, and you can see some examples of those, stretching from autism in kids, peer-delivered interventions for maternal depression, as well as now interventions for the prevention of depression. What we're now doing is actually even fast-tracking the development of these brief interventions, mainly because we know what not to do and how to do things in a more efficient way when we start at Premium. My own program of work right now is very strongly focused on young people, on adolescents with the age group of about 13 to 17 or 18 in schools. And my ongoing Wellcome Trust program is really developing a suite of interventions. This is a whole school intervention which again follow the same design principles, which is not really targeting individuals, but targeting the school environment, which we just published last year, which showed very large effects on improving population level mental health. And then a range of other more individually targeted interventions that again follow what I think is very important, a step care format from low intensity, guided self-help, digitally delivered interventions to more, as it were, high intensity interventions, much like we heard earlier today. I want to now end by just saying something about the transportability of some of this knowledge to places like here in Toronto and in the other country where I spend half my life now, in the US. So I was very impressed by this paper written by Jeannie Miranda, who's really one of the great innovators actually in psychological treatment work in the US, reaching populations that have been historically, in fact, disadvantaged in accessing psychological treatments, particularly African American and Hispanic communities. So she and a group wrote this paper in the annual review of clinical psychology, and it's a paean really to the innovations of global health innovators and really interrogating how this evidence must in fact now be, as it were, reverse engineered in the global north. And there's a very good reason for that. And that is, even in spite of all the enormous amount of investment that is made in the global north, far too many people do not receive even minimally effective treatments for mood, anxiety, and substance use problems. What is the proportion? Well, on this slide, I'm going to show you the minimum effective, the coverage of minimally effective treatment in developing or low and middle income countries, which I have to say I don't like this, this category because, there's nothing common between Shanghai and Kigali. Nevertheless, for historic reasons, we've lumped these completely different places together, and that's also a reason why the evidence base is often presented, lumping this incredibly heterogeneous group of countries into one category. There's certainly more homogeneity within the OECD countries. Nevertheless, what we're going to see now is the proportion of people with these three most burdensome in terms of prevalence mental health conditions in the population for minimally effective treatments. Now, here is the rates for the low and middle income countries. As you can see, astonishing, more than 95% of people do not receive minimally effective treatment. And when they do receive it, it's almost entirely always pharmacological. Now, let's now imagine a thought experiment of what the rates might be in countries which spend 1,000 times more on mental health care and have 1,000-fold more human resources for mental health care. Think of a number in your mind, and here are the rates. Now, this is pretty incredible that in spite of spending so much more and having so much more resource, even then, not even 50% of people in these richest countries of the world receive minimally effective treatments. And of course, IAPT was exactly designed to actually correct this anomaly. Now, the point that I really want to make here about this slide is that this suggests that simply throwing more money at this problem is not going to solve it. We're going to have to almost reimagine the way we conceptualize, organize, and deliver psychological treatment, so that the true lessons for global mental health, and I've really highlighted the word global here because in my mind, most global health disciplines are really about developing countries. You know, it's just a new word that is used to describe what 100 years ago we called tropical medicine. But actually, if there was one area of health which is quintessentially global, it's mental health. Because as you saw on the previous slide, every country is developing when it comes to mental health. So I think this is probably the one area of global health where we are all united in failure. And I think what we all can be doing, except Britain, what we can be doing a lot better is scaling up these brief treatments for common mental health problems in the way that I've already described. And so I was really delighted that I'm sorry to embarrass you again, that this program of work is being launched here. In many ways, apart from the, I would say, the disruptive nature of this work, it is remarkable that a US government-funded agency is supporting this kind of work. And this tells you something about the panels in the US right now, that is the review panels, that have also arrived independently at the same conclusion, that the ways in which we think about organizing mental health care must radically change if we're ever going to be able to reduce these large treatment gaps. So I'm thrilled not only for you, Daisy, but also to say more broadly for our field that review panels, research funders are also beginning to move in the direction of thinking about implementation as the single biggest barrier. So I'm now just going to finish off with just thinking ahead and what the continuing barriers might be that we aren't entirely sure how to deal with. We've talked about many of these in the panel earlier, the pushback from the guilds. I think it's important for us to keep at it, keep engaging with our professional communities. I think, I remember many years ago, there was the 100th anniversary of the American Psychopathological Association in New York, and I was giving the opening keynote with Norman Sartorius, who some of you may know is one of the most eminent psychiatrists who really was an architect of ICD, for example, ICD-10. And so anyway, we were sitting in the green room before the talk, and he said, Vikram, come and sit. You know, he's much senior to me, and so I said, I want to give you some advice. And I said, sure, you know, I'm all ears. And he said, Vikram, you've got a very important message, but I think you're giving it the wrong way. You are alienating psychiatrists by saying what you're saying. You are making them feel threatened. You're making them feel like you're dumbing down what they have spent 10 or 15 years mastering. And that is not the right way of saying things. And I heard him very seriously. I took his point, and he was absolutely right, that this is not about replacing people like us. This is not about dumbing down what we do. This is about ensuring that we use our training more efficiently to people who actually need 10 years of training in order to actually get better, and recognizing that a very large proportion of the burden of mental health problems probably doesn't need this degree of training as we have. And if we're ever going to achieve those treatment coverage rates that we want, business as usual won't happen. So lack of commercial incentive, I've already talked about the multiplicity of packages. This is a worry as well that many of my colleagues have. And then there's the issue of the low demand from the population and traditional methods of training and supervision, which I want to end with. So first of all, let me just tell you a little bit about two programs of work that I'm currently engaged with NIH funding. The first is to examine how we can engage communities to demand psychological treatments. This is really important in developing countries because historically psychological treatments have not been available. So there's a very low level even of awareness that these treatments exist. So I've been working in rural India, in the center of India, in which we were able to demonstrate through a concerted community engagement program that we were able to increase demand for psychological treatment sixfold in a space of 12 months. This is really important if we're going to address population-level impacts for mental health. care. And so I'm very fortunate that the NIH has supported us with an R01 to run a trial, at a cluster randomized trial in a whole state of India of 1.4 million people in order to examine how a community-based component can enhance demand for and coverage of effective psychological treatment for depression, which is the same BA treatment. And the second barrier is to do with learning, training, and supervision. And so another NIMH program is really examining how we can develop digital training for frontline workers, a woman like this lady here in a primary health center in central India to deliver behavioral activation. So one of the important barriers that we might face is, the acceptability of using smartphones to learn treatments. And, I remember people saying, are you sure that a frontline worker will actually prefer to, in fact, use a smartphone to learn how to deliver a treatment? Leave aside the question of whether it's as good as, because that's a trial question, but what about just acceptability? And so we've just completed some acceptability formative studies, and you can read these descriptions of women. These are, by the way, frontline workers. Most frontline workers have multiple responsibilities. They're not like us, that we have a 9-to-5 job, and then we go home, and then maybe we have the evening off. No, actually, these are mostly women. They never get the evening off. In fact, they have to therefore be doing things both for their domestic responsibilities alongside all the healthcare tasks that they do. And so when you pull them out and ask them to come for a workshop for 3 days, or even 1 day, it's a day away from something else they could be doing. There's an enormous opportunity cost. And that, of course, when you look at their narratives about using these tablets, most of these women don't have smartphones, but they absolutely adored engaging with these smartphones. And you can see there's some real advantages. You can dip in and out of the training. You can do it at your convenience. You can do it in the evening after you've fed your husband and your kids are in bed, etc. You can do it whenever you want, and you can keep revising as well. So it isn't the case that you go to a workshop, your mind is somewhere else, what am I going to cook for my husband when he comes home this evening, and you miss the whole bit of David's talk, and you say, oh my God, what did he say? What did he say? So you don't have to worry about that, because you can always go back and you can look back at your smartphone. To finish, the future. So the first thing is health systems interventions to build a community-facing workforce, extremely important. In many ways, I see this exactly like IAPT, except that the workforce would be quite different because we simply don't have that kind of mental health workforce that can deliver these interventions. But otherwise, I think the architecture wouldn't look all that different. We must recognize one size doesn't fit all, and we must really have a sense where this is seen as the foundation, but not the entire mental health care system. It cannot be, because no single intervention or delivery format can address the full range of mental health problems. But we must have this as a foundation for a balanced and step care approach. And lastly, I am very much hoping to look at a future where we can transform the way we train people. And to end, I'm just going to show you, I'm going to actually announce today that we are just launching a new initiative. We don't know exactly where it's going to go, but this short video will tell you a little bit about what that initiative's ambition is.
Health matters to all of us. Depression, anxiety, alcohol abuse, and trauma are familiar words, but we're not all familiar with overcoming them. Well, what if there was a new way to help? In fact, there already is. Research shows that brief psychological therapies can really help people to recover. If we receive the right training and support, then you can do it, and so can I. But if all this is true, then how come 9 out of 10 of us affected by mental health problems don't get the help we need? Because the old-fashioned ways to train and support people are expensive and impossible to scale. The world needs a solution, and we believe technology can help to provide the answer. We are designing a digital training platform where anyone can learn and master psychological treatments. We're empowering ordinary people around the world to deliver mental health care and to support those in need. We're building the world's mental health workforce. Join us.
And this is the Science Council, and you can see at least 2 familiar faces there. All right, well, thank you very much.
So thank you very much. It's more of a comment than a question, and it gets back to this multiple issues that you talked about. So first of all, absolutely fascinating work, and of course, we need this work to be done. It made me, when these issues come up about whether or not lay people can do psychotherapy, it always makes me think back to what little I remember from graduate school. But one of the things I do remember very clearly is the psychotherapy literature at that time clearly showing, and that was it must have been articles from the late 80s and early 90s, clearly showing that lay people could do psychotherapy similar to the level of highly trained professionals, not in these settings. And the uptake has been incredibly slow. So it's moving, but do you think this gets back to many of these issues that you've talked to us about as far as the barriers?
So you know what? You're absolutely right, and maybe some of you may not know this evidence that you're speaking about, which is how we reinvent the wheel. So actually, the word that was used was not lay people, it was called paraprofessionals. And it was a different context. What was the context? North America. When was this evidence? In the 1950s. In fact, when the first evidence on this was published, it created a storm, and I still have with me, for historical reasons, really good to know about the history of this, of any issue you work with, is the first systematic review that examined the use of paraprofessionals actually was published in 1968 in a journal that we don't probably read anymore called Psychological Bulletin, and it was led by an author called Durlach. And what's really interesting was what you just said, because that evidence is far more provocative than what I presented. That was professionals versus paraprofessionals. Now, as you rightly point out, that evidence showed no difference in clinical outcomes. The journal's readership was infuriated. And so the journal commissioned a fresh systematic review. There's a whole sequence of papers on this, by the way, that replicated that actually there was no difference in outcomes. And the research stopped. It stopped, it disappeared, and got resurrected by people working in the Global South. Now, what's interesting is people working in the Global South were not aware of this evidence, and this was only brought to my attention by someone like you about 10 years ago, by a colleague from Britain, who said, did you know that this evidence this evidence is like 40 years old? And so the question of why it is that this whole line of inquiry died is a really important one. It's like one of those, you need a historian to figure this out. What happened in the early 70s that squashed this? It also coincided at the same time with the emergence of the diagnostic system and with the emergence of ICD. That was around the time when we moved from more dimensional models of psychopathology to the binary categories, etc. So maybe there's something there, I don't know, I can only speculate. But you're right, there is a very big body of evidence. For those of you interested and want to make a case in the global north, just look at your own literature, but in the 60s, and you'll find stuff on this.
Because it was a series of meta-analysis.
Yeah, there was a meta-analysis too.
Right?
This was one of the earliest, actually, this is when the technique of meta-analysis was still very nascent, and one of the first times it was used was to compare professional and paraprofessional delivery of psychological therapies in North America. So it's a very interesting historical point. Thanks for bringing that up.
Could you tell us a little bit more about how the supervision and peer-to-peer supervision worked?
Yeah, that's a really important question. So the first thing to say is that by peers, we don't mean untrained peers, we mean people who are already competent. That is to say that they have already gone through training, they've already completed a competency assessment. That almost always also includes internships with real people who have the target problem. So these are not, as it were, naive to training. Then what happens is typically they will meet. At the moment it's face-to-face, but our platform is intended to make that fully digital so that you meet in like a social media space. What happens is that people's sessions are audio taped. Those sessions are heard by your peers. Typically they're also then connected with a case note, so you know a little bit about the person whose session you're hearing. And then you use rating scales that have been, you know, as much as you can, been shown to be reasonably good indicators of fidelity of how the treatment should be delivered. They're rated by your peers. You get a score, and you also get a narrative. And then essentially the discussion is really an enabling discussion in which your peers will explain why they gave you scores that they gave, to discuss what you could have done better, what you did very well. Also, this is about positive reinforcement. And so that's what happens in a session. Actually, it's not very different from what you might imagine you might do in a psychotherapy supervision session, but it's actually being done by peer supervision rather than having an expert. Why? Because there are very few experts. The other thing I will say is that as you build a community of peers who become more and more experienced, they become experts themselves. And they can actually then double back and help supervise the next generation of learners.
Just a wonderful talk, and it was so wonderful to have a summary of where it is up to. And I fully buy the argument of reverse engineering to the first world as well, I think. So we learn a lot from what you've done. Early on in the talk, you were alluding to the issue of sort of take-up in the countries once you've done these research studies. And I wondered if you could tell us a bit about how that's going and what are the sort of barriers to it, and what's your next step to solve them, because I'm sure you will solve them. But.
Yeah, well, certainly, I mean, I would say I am very inspired by the one program that you described this morning. I think there's a lot we can learn from this kind of system-level scale-up that you've managed to achieve. Many of the ingredients that you described, we've also tried. And actually, the very fact that resources are being allocated to mental health. In the month of June, the World Bank is having a small meeting of largely, bank leaders to mobilize a $10 billion fund for scale-up. This is not insubstantial in our field, as I'm sure you'd appreciate.
Well, it buys a lot when it's only $2 a
Exactly. Page. Well, yeah, exactly. You can begin to see. I think money is less of a problem, David. I think it's systems, and I think you're right to say it isn't the case that we can just train providers and start working. They have to be working within an enabling system, and that means, and this turns back to a question that I have for my own colleagues in psychiatry and psychology: how can we be active ambassadors for building a system in which frontline workers are being trained and supervised, that they are directly connected and embedded with our own practices, so we don't see this as a parallel and separate system, but actually one that is actually an outreach program of our own effort. That, to me, is structurally a very important next step, is engaging the established mental health care systems in different parts of the world to actually begin to employ the frontline workers using money that governments are making available and to transform their training. But there is another connected problem, which is that you spoke to this, which is that many psychologists and psychiatrists are not delivering evidence-based therapies themselves. And I actually would turn that question back to anyone here in the audience. How do we get people who are highly trained to also deliver evidence-based treatments? It would be paradoxical that we are using evidence-based treatments for frontline workers, but actually within the mental health professional community, that is not always taken for granted either.
I learned that actually the least complicated but at the same time effective elements of the mainstream treatment modes actually are taught to the lay providers. And still it remains some evidence-based actually practice or therapy. What about actually integrating, though it might not be evidence-based then, but integrating some indigenous, local, spiritual, or even therapeutic aspect of each culture into it? I had a colleague who went to India and he had a tour of the correctional centers over there. They don't have like what we have here, psychiatrists, psychologists in their correctional centers, but they have people who come over there like 2 times a week to do in group yoga or meditation. And my colleague actually told me it was very effective in actually helping the inmates be stabilized or actually kind of functional. And it can be even applied here in Canada because our cities, great cities or big cities aside, We have small communities of indigenous or aboriginal people, not necessarily up north, even in Ontario, communities of 600 people with a very high rate of alcoholism or actually substance abuse problem or different problems. And they don't have access to any form of mental health. And actually considering their own rich culture, even therapeutic actually aspect of their culture, it can be done both in terms of what you're suggesting in combination of integrating those aspects of their culture into it.
Yeah, so I completely agree. In fact, I think you gave the example of yoga. I think it's probably no longer an indigenous practice in India. It seems to be more people doing yoga in Toronto maybe than in Delhi. But jokes apart, the real issue is about scalability. I completely agree with you. Actually, the challenge is how do you take these practices in ways that can be replicated at a scale that is needed. And yoga is a very complex. It's a whole philosophy. It's an incredibly complex tradition of techniques and skills. There are more than 30,000 different techniques in yoga. So it's absolutely true that I am personally extremely open-minded about incorporating indigenous healing practices. The question for me always is the challenge of how do I package this in a way that can be scaled up in a way that assures the quality. Many yoga teachers will tell you that can't be done with yoga. They will say, no, this is something that you have to be embedded in. You have to go through, a bit like PhDs in clinical psychology, learning CBT actually. And so somebody needs to do the same thing with yoga as we are doing with psychological treatments. One component of yoga that has made that leap is mindfulness. If you look at the history of mindfulness, in fact, it's a technique which comes from meditation. And that in turn comes from a form of Buddhist meditative techniques, which are very similar to meditation that is practiced in yoga. So, colleagues, in fact, in Oxford have been able over decades to be able to characterize this particular technique in a way that can be taught, can be learned, can be therefore scaled up. And maybe that's something that we should be continuing to explore. Maybe there are other such techniques as well that can be scaled up in the hands of, for example, frontline workers.
Are you sneaking in one question, Dr. Roberts? Go ahead, go ahead.
First of all, I want to echo thanks. Incredibly inspiring to hear about this body of work and also to have had the opportunity to work with Claire in Ethiopia, inspired by this kind of the philosophies and actions. And my question is, actually I had a few questions. You can choose to not answer them all. But one is, there is scalability, but then there's sustainability. And I think that those are two different things. And Claire spent a sabbatical year in Ethiopia ensuring that we scaled what we sought out to do, which was to train 500 nurses and screen tens of thousands of patients and treat them. But it was always a worry that, as soon as the project ended, would all these people that we trained, would they continue to take the extra time in a very, very busy primary care practice to continue to screen and provide the treatment that they had become competent in delivering? So I'm interested in your thoughts about that. And also, another idea is just that in developing countries, we have these vectors of providers who are actually on the front lines of care, but who are not delivering evidence-based treatment, nor do they get training in it. And one group that comes to mind are what we call case managers in Canada, that work out of these on teams and in community-based mental health groups. And they're just kind of flying by the seat of their pants, and they're helping people with very pragmatic aspects, often to do with these issues around class. So insecure housing, insecure income, food insecurity. But they also really can and want to do more, because the individuals they work with often have problems with anxiety, depression, or substance misuse. And so they have been it's almost like they've been so hungry and excited, enthusiastic, and appreciative to learn a compendium of some of these pragmatic psychotherapy principles and skills that they can integrate into their encounters with their clients, not delivering a bona fide treatment, but still delivering treatment that I think has improved their outcomes and improved their ability to give time-limited treatment, to discharge them and then see other people, because they're not just addressing the social determinants of health, they're also addressing their mental health.
So thanks, Paula. Let me respond to the second question first. In fact, that's exactly what we're trying to do in probably the world's most well-resourced city in terms of mental health care, Boston. So in collaboration with the Center for Primary Care Medicine, we're working with community health. I don't know how many of you know there are community health workers in the US. There are community health worker associations. There's a state association in Massachusetts. And so the role of community health workers has been predominantly addressing social determinants of health. And so the question you're asking is, can we actually add to their curricula training, for example, in brief behavioral activation as the first line? And again, this ties in very much with David's ongoing work with long-term conditions. So that's exactly what we're doing right now. We're doing initial pilot work in which we are training frontline workers in Boston and more broadly in Massachusetts to deliver depression interventions for people with chronic medical conditions who also have depression. And the aim is to also add alcohol-related psychological interventions. The problem is this is all happening under the radar. Because the question is about reimbursement keeps coming up. And we're very lucky that apparently in Medicare that there is a reimbursement code for community health worker delivered interventions, but it's very general. It doesn't really specify what. So you can have a reimbursement code. This sounds really not science, right? But it is important because it really goes to the point of sustainability. Because if there is no financial system to actually pay for this, then it won't happen. And in order for us, if we really, as a professional community, are passionate about getting our interventions out, we're going to have to engage with that very important piece, which is the payment mechanism, the reimbursement mechanism to ensure that these frontline workers are appropriately trained and then are appropriately, as it were, recompensed for their work. That takes me to the point of sustainability. I agree with you, there are fundamental differences, but apart from money, another very important difference is demand. You know, at least in democracies, and once a healthcare system is functioning, if there is a demand for something, then the government has to continue it. It would be simply not acceptable if you've generated a demand, 1 million people are coming for a particular intervention each year, and then suddenly someone says, oh, I don't have money to spend on this. It's not democratically possible to do that. Once there is a system in place, demand from the population is the most important way to sustain it, because it's politically suicide to actually turn the tap off.
Thank you. Oh, right. Go ahead.
A comment and a question. You have a question?
No, I was just wondering whether Claire wanted to add any comment from...
No, I completely agree. Demand is what would sustain the system. Thank you.
It's a true pleasure. It's a wonderful talk. My personal interest is, one of the interests is global psychiatry. It's one giant introducing another in the field of global psychiatry. And Claire, I know you're very modest, but so much great work over the years. And I really appreciate you being the moderator here. And Vikram, obviously. I have a question. You know, I spent the first 10 years of my life actually in Africa. I've been to Harare. I was in Botswana for quite a bit of time. The challenge that I still hurts me is, I was in a conference in Prague, child conference, and they're talking about in Botswana, for example, there is one psychiatrist. Now that's 20 years maybe after you were there in Harare, and you were saying that you were one. I mean, what is the possibility of getting governments to engage in understanding mental health, or even training people to provide mental health? I mean, I think we need some type of leaders, psychologists or psychiatrists, to be in these African nations to, promote this, to at least, think about sustainability or scalability or something of that nature. So what are your thoughts on the barriers there, and what are your thoughts on how this could be changed, or just?
So I do think what you're speaking to is the need also for more mental health professionals. This is a very big need, and by mental health professionals, I mean people who have a more specialized knowledge of the field, because community health workers, once they're trained, are also mental health professionals, but they're task-based providers. And I do think that this is a very important question, is can we continue training people the way we currently do to become clinical psychologists and psychiatrists? Is this really the only model of training? And I think we have to start asking those questions. In a completely new world with digital opportunities and so on, the use of frontline workers, a public healthcare approach, etc., is our training actually 18th century? Where do we have to reimagine the duration of training, the content of training, the way the training is delivered? If we are talking of training frontline workers digitally, is there also perhaps some potential for imagining similar kinds of training platforms also for people, let's say psychiatrists? Seriously, do we really need to put people through for 3 or 4 years of training to become a psychiatrist? Maybe yes in certain settings, but is that true in all settings? Could there be, for example, a shorter, more task-focused, clinically oriented training, which also includes roles that we heard earlier today as well about management of systems, management of a public health workforce, etc. Our training is still so out of sync in many ways, from the Global South perspective anyway, with the kinds of needs in psychiatry and psychology, that I do think there is a need for that kind of conversation. I'm not part of that right now, but I hope certainly that the WP and other organizations are in fact trying to address this question. All right, thank you.
Thank you again,
Thank you
Vikram,
very
for a
much.
wonderful
Thank
talk.
you.